take home message. And now I call upon Dr. Matthew Kurian to talk about loss of rhexis integrity.
Thank you to Dr. Sudeep and Dr. Sai for this opportunity. While my video loads, so the amount of haptic deduction from uh, Dr. Minu's talk, we call it haptic deduction at source. Just like tax, 10% is acceptable. Anything more than that, you have to explant the lens. Okay. So I will be talking about loss. First thing is you have to recognize that it has happened. And in this situation, the cause for this happening is that we have used HPMC and cystitome in an intumescent lens with raised intralenticular pressure. Here there is no raised intralenticular pressure, but as we complete the rhexis, this is a resident doing. At the first step, comes out and then overinflates the chamber, and some of that visco enters the lens, and that causes the raised interlenticular pressure and the split. Uh, Another case here is we are using HPMC, microrhexis forceps, which is good, but HPMC is not enough to dampen out the raised interlenticular pressure, and that runs to the periphery. Here, HPMC and cystitome, intumescent lens, Argentinian flag sign, that's very familiar to all of us. And finally, we have a possibility of instrumental laceration. So side port instrument caused a puncture there, and we were able to luckily uh, retrieve the situation. Mitigation, all these situations, if it is associated with raised intralenticular pressure, decompress the uh, capsular bag. Usually there will be some amount of fluffy cortex that is there, and then convert it, if possible, into a proper rhexis, or in most of these cases which have run into the zonules, to do semi-rhexis, because you will not be able to complete rhexis without damaging zonules. So a semi-rhexis like this is one side. Another option is to go for a proper can opener, and I personally prefer a can opener in these kind of situations, because if you just have a few areas of zonular loss, then that can extend to the posterior, the double hemirexis in the central split of the Argentinian flag sign. And the best possible option is to be able to uh, recognize the loss of the anterior capsule, but include it into a large and maybe slightly eccentric rhexis. So these are situations that happen in the initial steps of surgery itself, and you are able to recognize and mitigate the problem. Another situation here is where we have used trypan blue to visualize the anterior capsule, sodium hyaluronate and chondroitin sulfate to flatten the anterior capsule, but it's a very small rhexis. And you see here at an early stage, it was recognized that the sleeve has lacerated the capsule, but it has not run to the periphery, and a double rhexis is possible in this situation. And this could have been mitigated by making a more appropriate sized rhexis initially. Um, this is a femtorhexis. Surgery has gone well. At the last step, after the IOL implantation, go under the capsule, under the IOL, and here you can see the rhexis margin gives way. So just remember that the femtorhexis is not as flexible as a regular manual torn rhexis. In this situation, the rex is not extended. Last step, no subsequent consequences other than possibly a slight dislocation of the lens. I decided to uh, maintain the anterior chamber pressure, hydrate the other wounds, and close it, and leave this intact without doing anything further. Fortunately, the haptics are 90 degrees away from the extension, and I was able to leave that. Other situations when we are recognizing the rhexis run off late and then need to manage major complication. Here, fellow has operated and has not recognized that there is an incomplete rhexis. During hydro, failed to recognize the tipping of the lens, continued with nucleus management, once more failed to recognize that there is a tipping of the lens, attempted to continue with phaco, and then recognized that there was a problem only at the end when the nucleus goes down. So at this stage, you should not panic, withdraw the phaco, maintain the chamber, but that's exactly what is not done over here. The chamber collapse allows the nucleus margin lost. Uh, all we can do at this stage is to clear up the anterior chamber of any vitreous prolapse. So this is cut mode to clear the anterior chamber of any prolapsed vitreous, which is caused because the phaco handpiece was withdrawn without maintaining the chamber. Then move from cut uh, aspiration to aspiration cut, where in foot position 2 there is aspiration, the cut rate comes down. You can see the cut rate here is less, and then you are aspirating. So this mode I use to remove any residual cortex, and whenever prolapse of any vitreous happens, I go back into the cut IA mode, and then I am able to clear any of the vitreous which is here. You can clearly see the rhexis extension that has happened because of the incomplete rhexis. All I do here is no fishing, close the wound, and send it off to the retinal surgeon to salvage, complete the posterior. I don't place a lens here because of the incomplete rhexis, and retinal surgery manipulations may cause it to dislocate further. So there is a sudden appearance of red reflex in some situations. Here, it's a fairly hard nucleus, so primary chopping did not work. There is a little bit of iris flutter, iris prolapse is happening over here, and chopping maneuvers have to be done a little blind under the rhexis, under the smaller pupil. So at some point in this, the rhexis is damaged. You can see there is a difficulty in sort of impaling and getting the nucleus fragment, uh, and this is one of the early signs that there may be some vitreous in front. The struggle continues. The harder nucleus, one fragment goes in, another quadrant goes in, and smaller fragment. A heminucleus is remaining at this stage. It's tipping, difficult to rotate. These are all signs that the posterior capsule has given way, most likely due to the blind chopping procedure which caused a rhexis extension. At this point, finally, the surgeon realizes that there may be a problem, and then gives way to the senior surgeon to take over, examine the area, identify the presence of a rent, use two Sinskey hooks to bring the fragments away from the area of the rent into the anterior chamber. Because this is a very brown cataract, a peripheral rent which is of an uncertain dimension, we decided to convert, since it was a primary slightly posterior sclerolimbal incision, we were able to convert that by back cuts on both sides and visco express. Now you can see the rhexis extension as well as the posterior capsule rent. And in this case, we need to then plan to place a 3-piece IOL in the sulcus, but making sure that the haptics are oriented away from the area of the rupture. That was a 3-piece, okay. And the risk of rhexis extension we can make out very well in this situation where you have pockets of fluid. So if you have anterior pockets of fluid, puncture will cause the pocket of fluid to come out. The raised intralenticular pressure is reduced, and risk of rhexis extension during rhexis is reduced. But if the pockets of fluid on OCT are much deeper and you have layers of cortex on top, there will be sustained raised intralenticular pressure throughout the rhexis, and even at a later stage, you may find that the rhexis will run to the periphery. Thank you very much.
Thank you very much, Dr. Matthew.